Okay, we will go ahead and get started. My name is Carrie Neiman. I'm an otologist here, core faculty at the Johns Hopkins Cochlear Center for Hearing and Public Health. Welcome to our first seminar of 2025 and continuing our 2024-2025 series. I will go ahead and go through some of our slides here. Just as a reminder, we will take Q&A afterwards. You can use, for those joining us online, feel free to use the Q&A feature. We'll also obviously take questions from panelists in the audience members in the room. Closed captioning is provided, and information is there in terms of accessing the transcript there. Please reach out if there's any technical difficulties at that email address. Looking ahead to the last couple of seminar series for the year, we have Adam Spira and Jeanette Mahoney who will be joining us, so save those dates. And then, as always, ending up the year with our Cochlear Center Research Day on April 25th, and we're really excited to welcome Laura Nyblade, who will be focused on stigma. So with that, I will go ahead and introduce our speaker for today, Sumit Dhar. So Sumit Dhar is the Huell Knowles Professor of Hearing Science. He's also the Associate Provost for faculty at Northwestern University. Sumit's research group has really two kind of main areas of focus. One is in the area of early and accurate detection of inner ear damage. And then the second, which I think is more closely aligned with our work here at the Cochlear Center, is improving hearing healthcare. So in their team's work on inner ear function, the group uses otoacoustic emissions and other assays to detect changes in the cochlea and identify pathophysiology that is responsible for that. And then in the area of hearing healthcare, his group examines barriers to access and affordability, and really a focus on designing patient-centered solutions to dismantle those specific barriers. He is funded from a number of different organizations, including the NIH and PCORI, as well as work with private foundations and industry. And it is also my personal honor to welcome Sumit here as somebody who we have been working very closely as steadfast partners for the past year, as co-leads for the NIDCD's working group on affordable, accessible hearing care for adults, and associated efforts in that line. So thank you very much, Sumit, for joining us, and welcome.
I'll just get us going. Thank you, Carrie. Thank you, Frank. Thanks, everyone. I've been an ardent admirer of your work from distance. So I'm glad to be able to come spend a bit of time with you, share our work. And my goal is to talk very fast so we can save enough time to answer questions or hear what you have to say. So that I say that because I want to invite you to stop me, no matter where I am, if you want me to dive a little bit deeper into something or need clarification on something else. Good? Thank you. Okay, so here we go. As Dr. Neiman mentioned, we started out, and I still do work in cochlear mechanics and otoacoustic emissions, but that's not what I'm here to talk about today. I'll share some work with you in this other line of work we do in health service or hearing healthcare service. And this is purely by accident, I might say, that we got going here. So I'll establish why that work is important, a point I don't have to make here. And I'll talk a bit about how I end up here giving this talk, and it may be relevant to those who are going through the journey of figuring out what kind of science they want to do, and then give you small bits of stories about two specific projects that we have done in this area, and then share some thoughts about where we go from here. Like I said, I'll try to save as much time as possible for us to have a discussion. So to establish need, here are some numbers that I have put together of the millions of people in the US who have adults who have mild or moderate hearing loss. Now, elsewhere, I could get into some kind of quibble about whether this number is absolutely correct or not. It's safe here because you can fight with yourselves. These are all your numbers. And one from a 2016 paper and then a projection from a paper that came out next year. That puts us at a whopping 70 million individuals with mild or moderate hearing loss who are adults in the US. Now, these papers present these numbers carved out in different ways. I have simply taken everybody who's 20 years or older and would get categorized as having mild or moderate hearing loss because the focus of today's talk is over-the-counter hearing aids, and that's the population that this technology and this service delivery mechanism is targeted for. Now, it's always good when you can take data that are from today to validate forward-looking models, and you can do that. Here's a 2024 paper in green from Rain et al., and then 4 collections of models that Larry Humes published in the last couple of years of various estimates of how many people there might be in the US with mild moderate hearing loss. In Larry's work, the open symbols are self-report, and depending on what question you ask, you get very different answers. And the 2 closed symbols are measurements of hearing thresholds. We could all agree we are somewhere between 40–50 million folks today who have mild to moderate hearing loss. How many of these folks are we serving? The answer is not many. Here are the pairs of hearing aids sold in the US over the last 5 years. And if you can't see the numbers because they almost fall off the graph, but the gap is enormous, and that's why we all do what we do, trying to get more help or help to more people who really, really should use it. Okay, so this recognition that there's this big gap has sort of started this field of affordable and accessible hearing healthcare. And the very first salvo at the national level was this 2009 NIDCD workshop that was organized by Amy Donahue, Judy Dubno, and Lou Beck, that then led to a cascade of events. Now, I want to intersect that with a personal journey, because right before this happened, I was in my lab doing, measuring spontaneous otoacoustic emissions that me and 5 other people in the world cared about. And Amy Donahue called and said, you should come to this workshop. And I am a big believer in not misutilizing resources, and inviting me to that workshop was a clear misutilization of resources. So I argued that they should ask someone else to take my spot, because she said there were 30 spots. And it took 2 more phone calls. The 3rd phone call, Amy said, put the phone down, buy the ticket. So I went, and it has literally changed what I do because of what I learned from others at that workshop. But as you all know very well, that led to, amongst other things, PCAST report, a NASEM report, the over-the-counter hearing aids bill, and then finally the 2022 FDA regularization of OTC hearing aids. It is absolutely worth taking a moment to recognize the tremendous and influential role that folks in this room have played in this journey. I don't think we would be here by any means without the advocacy, the scientific data that were presented to these groups from this center. So I feel especially grateful to be able to be here today, and I wanted to take a second to acknowledge that work. Okay, so at this workshop, after 2 days of discussions with these 30 folks, you come away with this sense that, okay, there's hearing loss and hearing health, and there's, hearing aids that could be potential treatment. There are all these bricks in between that are the barriers to access to hearing healthcare. And the 3 that I focused on, I don't know why. One was the cost. That was a big part of the discussion. And I'll just preview now, a lot of folks at that in that group thought that was perhaps a cure-all. I didn't think so then, and we now know that is not the case. Then one thing that drew my attention was this idea of a medical clearance. At that time, if you wanted a set of hearing aids, you would have to go see a physician who would sign a piece of paper saying you don't have some other kind of ear disease, like your eardrum's not ruptured or you don't have a neuroma or something. And then you could go back to your audiologist or wherever you were getting your hearing aids from to get your hearing aids. I've got two problems with that. One, it's 6 months and another $150 to get that form signed. And two, there's also this provision where you could sign a waiver. Like, how could both these things exist at the same time? If it's that important that you go see the highest level provider in the land to get certified that you can get hearing aids, how could you turn around and sign a piece of paper that said, okay. So that was stuck to my head. And then from a sort of technical point of view, there's this other point made that fitting hearing aids to a hearing loss is this highly technical process that you just can't trust a run-of-the-mill consumer to be able to do. So I came home and these things were rattling in my head and I saw this paper. This was out of the Mayo group in Florida, and they were asking a different question. They were asking whether they could have this disease screening before hearing aids done by audiologists and not neurotologists or otologists. And they show in this paper that audiologist screening is just as successful or just as efficient and accurate as neurotologist screening, and they were going to save time by letting the audiologist do the screening. That made me think, well, what if we went a step farther and asked the consumer to self-screen? So I contacted Larry Lundy, who was chair of otolaryngology there, and David Zappala, who was chief of audiology, and said, hey, I read your paper. Here's what I would like to do. And they were on board. Larry, who's retired now, got all neurotologists in the Mayo system involved, and I was very grateful for that. And I'll walk you through what we did very, very quickly. So basically, what we wanted to know is which diseases do we need to worry about? What does a physician, how does a physician screen for these diseases? Now, this is before any studies have been ordered. This is just at the physical interview level. And can these questions be answered by the consumer themselves? If so, could we build a questionnaire that would serve that purpose? So we went about and first cataloged all of the diseases that we were told we needed to worry about and had the Mayo neurotologists rate them on 3 scales. Here is the likelihood of the disease appearing on its own as hearing loss and no other symptoms. If that is very high, then that is one kind of disease. If there are many other symptoms, like your ears are bleeding, that's just another category of things. And on the x-axis is the consequence of missing it, right? So if you miss the disease, you would die in 4, and nothing would happen if you're at 0. And the size is the difficulty of diagnosing. Our fear was that all of the diseases we need to worry about would cluster in that top corner. That is, that hearing loss is the only thing that it shows up in that disease. And if you miss it, it's very fatal. That wasn't the case. Most of it clustered in this corner. Yes, it is, you should misdiagnose or miss the diagnosis of the disease, but there are many other symptoms you could count on. So that led us to try to develop a questionnaire. We asked all the neurotologists to submit all of the questions that they ask of a patient when they see one, and they turned out to be more than 350 questions. You run it through a pattern recognizer, ended up with 30 themes from all of those questions. We took those 30 themes, went back to the neurotologists, and asked them to create questions that would address those 30 themes. Came up with 30 questions. Did some cognitive interviews. Now, at this point, I'm working with someone who builds questionnaires and built a questionnaire that was answerable or usable by hearing aid seekers, ran a trial, and it turned out that we could achieve the same outcomes with 15 questions of that 30. So we built this very simple questionnaire. There's some yes, no questions and some ratings, like how would you rate your health? Very good, good, poor, or very poor. And you would take these answers and put them in here, where a bunch of questions you get 1 point if you said yes, and some other questions, depending on your answer, you get a point or not. You add them all up and you get CDRA score. If the CDRA score is 4 or above, you're at high risk for ear disease. You should go see a physician. If it's less than 4, you're probably okay to get hearing aids. That was the idea. We did a clinical trial in 4 sites across the country. The ROC curve looked really good, so we published the questionnaire. And the questionnaire was, the paper was published in August of 2017. All my lab thinks that because of this in 2017, the FDA said we don't need to do physician clearance anymore. That's not the case. It probably helped. So today you could go to cedra.northwestern.edu and click on what's my risk, and it would walk you through these questions, do the scoring, and and it would tell you whether you need to go see a doctor or not. So in this process, what we think we've done is we've taken a big one of those bricks that was a barrier and created alternate pathways. If you need a medical clearance, you should go do that, and that's the safe way of proceeding. But in case you don't, we have created a faster path to access hearing aids. It is getting some traction. For example, lots of direct-to-consumer groups use it at the front end of their apps to do a case history cum risk assessment. Some direct-to-consumer companies, used to be Lively, now Jabra and Hands, are also using it. Interestingly, there's some use outside of hearing healthcare. There's this chain of clinics that does Medicare intake in Central Ohio that has kiosks that you answer lots of things on. And this is one of the questionnaires. So people will call and say, hey, what will it take for us to use it? And I say, nothing, download it and use it, because it's published. So it's gone really well, and it's catching some traction. So it's one example of just removing one of those small bricks that form that wall or barrier to hearing. So pause there for a second, see if anyone has any questions, reactions. Yes, sir.
Can medications be also a cause of hearing loss? Certain medications?
So there's this whole family of ototoxic medications that are known, and most people who would prescribe medications know those and would probably warn you. Again, there are more qualified people in this room to answer this question, but I'll just say that the ones that are known culprits, a lot of them are used in cancer therapy, and sometimes it's a choice to change regimen or change to a different drug, but sometimes the primary need of the day is to fix the cancer.
Yeah, quick question. Even like historically going back decades, there's the traditional the FDA red flag criteria, right? Training year, things like that. Has anyone ever looked at like performance of those old red flag conditions versus like Cedra?
Yeah, so before we published this paper, we did a analysis of the FDA red flags and then the AAO red flags. Forget which one, but both are hypersensitive. So one of them refers about 86% of the people. So I mean, it's as a screening tool, that's great, but it also may not be the most efficient path. I can send the paper to you.
But those are actually more sensitive than Cedra.
Yeah.
Yeah. Okay,
but probably over refer as well. Yeah.
Thanks.
Okay, so now I'll then switch to the main story for today. And this goes to this question of, can people fit their own hearing aids or not? This journey started after I got back from that workshop in sort of figuring out, well, what can we do to help people fit their hearing aids? That time, Andy Sabin was a PhD student at Northwestern, and the two of us, we built this little app where you had a ball inside a square, And the person would just place the ball somewhere within the square. And that would change 3 filters in the output of a sound, and you could change the tonality of the signal. And what the task we gave people is something like, make this sound hollow. And we just let you place wherever you thought it was hollow. Make this sound tinny, and you'd place it wherever. So what we ended up with is this, where we have 10 people with different kinds of hearing loss, and these are the filters they built. Right, and so let's take hollow. You can see most people do what we think would be hollow, is a lot of output at the low frequencies and not much in the high frequencies. But there are a few people who are completely the opposite, who emphasize the high frequencies and not the low frequencies. Nonetheless, this told us people can control the output of the signal and make it sound the way they want to make it sound. So then Andy went off and spun out a startup called Ear Machine and built a fitting tool that had 2 wheels. One was overall gain and the other was tilt. Okay? And then Andy sold to Bose, and that was the genesis of Bose's first self-fit kind of de novo hearing. So this was the beginning of that work. And once Bose had a device, we did the clinical trial in the lab that led to the FDA approval. And unbeknownst to us, around the same time, Larry Humes also was doing a placebo-controlled OTC trial at Indiana University that showed that people could self-fit and get the same outcomes. So when these were done, Larry and I teamed up. These are the 2 papers that came out of those 2 projects, teamed up to write to PCORI to do what I'm going to share with you today, the patient-centered hearing aid trial, where we took the protocols we had developed, but condensed it down to something that we thought could be commercially applicable. That didn't take an hour. That took about 7 minutes each to fit. Still very crude, and I'll walk you through that. But that's sort of the genesis of this project. This is how we advertise the project. 4 centers, 2 in Chicago, 1 in the Chicago suburbs, Sertoma, and then 1 in Galveston. We had variations of this photo, and this is the advertisement that went out on social media, print media, etc. And we got going. I wanted to acknowledge all of the people who helped. This is our team at Northwestern, a group of 15 stakeholders who formed the advisory group. They were invaluable because, as you'll see in a second, this started during the COVID, and no one wanted to come do any of this. And advice from this group, they featured in video ads, to the community, all that. They really helped us going. And these are the 4 clinical sites where the work was done. Okay, so just like I said, we got the grant in June of 2020, and then nothing happened because we couldn't get people to come into these sites to get these hearing aids. So almost a year and a half later, we had only 25% of the people enrolled. And for those who write to PCORI or have already written to PCORI, they are worse than defense. They want a report every 6 weeks. And if you've fallen behind by 2 participants, why are you not enrolling? What can you do to make up for that, et cetera, et cetera. I'm glad they were on top of it because it kept us honest as well. I also show you this because what we felt and then saw in the numbers, as news about OTC hearing aids got out, the numbers picked up. And once OTC hearing aids were official, we had a wait list, right? And then we ended our enrollment in September of 2023 with as many people waiting to do another trial. So I don't know what exactly it has done to the actual hearing aid marketplace, but we did see an effect. Okay, so here's what happened. We advertised to recruit between 50 and 79-year-old, self-report hearing difficulty, never had used hearing aids. We did an online pre-screening, and then they came in to the first session, confirmed their eligibility through audiometry and other things, randomized into 3 groups. AB, the audiology best practice, CD, consumer decides EF efficient fitting. We thought we'd call it the ABCDEF study. It's not caught on yet. So CD is Larry's protocol condensed. EF is our Bose protocol condensed. And I'll tell you what they are in a second. They came back in 6 weeks, first set of outcome measures. This is the primary endpoint. And then a lot of them came back in 6 months to get a longer term outcome measure. Okay, this is all the details of what happened in each session. We can go back to it if needed. Here's eligibility, self-reported hearing difficulties based on their HHIE score, no prior hearing aid use. MoCA score, we started with 26, we had to drop to 23 because we were rejecting a lot of people. And, Carrie has pointed out future trials, we might have to rethink that. Then when they came in, we made sure they had at least 1 year at one frequency greater than 20 dBHL. It's kind of arbitrary, but that's where we settled. And then we also didn't want severe hearing loss, so 4 frequency PT or the hearing number, no worse than 50 dBHL. And then some symmetry in both ears. Okay, so this is again overall picture. So we screened 1,127 people, ended up enrolling 584 after the several stages of screening. And I wanted to show this because when we started out, we put a lot of effort into advertising online, newspapers, etc. As the word about OTC hearing aids started to get traction, and some people had gone into the study, word of mouth far swamped anything else, to the point where we stopped spending money on all these ads. It was purely word of mouth after maybe 25% enrollment that drove enrollment into this study. So again, something we learned. Here's how people dropped out between sessions. Want to point this out because we only lost 9 and 13 to follow up in the 584. So that's pretty good. What I also want to point out that 19 refused or couldn't finish, and I'll come back to that in a second. 24 returned their devices, and I'll come back to that in a second. And these 54 dropped out after session 2. They just didn't want to wait 6 months to come back again, but they finished primary. Yeah. Okay. So this is the flow of numbers I've shown you already. This is the consort diagram. I'll pull out the relevant numbers for you. So in these 3 randomization groups, we have 190 who were allocated to the audiology group, 193 and 201. And first set of things to point out is one person declined here, probably because of price. Everybody had to buy a pair of hearing aids for $650. This is happening before OTC hearing aids. We had no idea what price point they'd come in. We thought 650 was a reasonable place to be. 12 either could not finish our self-fit or did not want to pay or something or the other. 6 in the third group, same boat. Some of these 18, once they recognized they were randomized to a self-fit group, said they would only participate if they could see an audiologist. That was sort of an unexpected outcome. Okay, so here's what we fit them with. High-end receiver in the canal hearing aids. They would retail for probably $5,000 a pair. We had a deal with the manufacturer. We could sell them for $650. We did not advertise the discount. We didn't want it to be a motivation for people to participate. We did not advertise the make and model. Over time, once people had them, it kind of became sort of folklore or knowledge that was what was being fit. Okay. CD and EF groups, These are the self-fitting groups. I'll walk you through their self-guided measure. They had to make some choices: wire length, dome size, color, acoustic program, all of these things that were done by the audiologist in the AV group. So let's take a little detour and I'll walk you through the fitting process. Everybody, now this is a critical thing. Everybody in the CD and EF group was presumed to have one audiogram. So we wanted to artificially make it as bad as it could get, right? So this is, we don't know you're coming into some retail place to get an audiogram. We will not even measure your hearing, which we can and we would, but this is the audiogram we started with. How did we get to this audiogram? This was the most common audiogram in the 2 previous trials that Larry and I had done. So we had some confidence that a lot of people would be near here, but still, we're starting with one audiogram. Can't get simpler than that. Then in the CD group, you started with the blue line and you could play around with a remote control to change the output of the hearing aid in one of those 4 categories. In the EF group, you could not change the low frequency gain, you could only change the high frequency. Very simple adjustments. And our idea was to say or ask, we don't know what the technology will look like right out of the gate when OTC hearing aids come out. What if it's the simplest possible iteration? Will it still be useful for folks? Here's how they fit themselves. Again, a crude setup. Remember, this is pre-OTC hearing aids. They would be in a room with a mirror, a speaker that would play sounds, a Tupperware box with things I'll show you in a second, an iPad app that we built, and a call for help button. And they would be on their own. They could hit the call for help if the app froze, which it did every once in a while. Otherwise, they were on their own. This is what the box looked like. Here, each of the compartments has a symbol. This is what the app used to direct them to one of the compartments. This set of compartments was the color choice. You have 3 colors of hearing aids. These other compartments have some combination of dome size and wire length. And we've gotten data from this hearing aid manufacturer to zero in on these combinations because that's what they sold most of the time. Here's how it would go. The app would ask you to put a set of hearing aids in and would ask you if it looks like this, where it's a good fit, or if it's a little baggy. And say, oh, choose a smaller one so it looks like this. It would walk you through these steps. Similarly, it would ask you to pick one of the colors up, hold it up to the mirror, see which one you like, and you'd pick that choice of the 3. For acoustic programming, you would, if you remember, each of these boxes had a remote control with it. So the 4 settings for each hearing aid were programmed into 4 programs. They could just click through. So when they got here, they'd pick a hearing aid, the app would play speech, and you would rate how you liked it on 0 to 10. Then it would play music, it would play everyday sounds, you'd rate it. And you'd do it for how many ever settings how many ever hearing aids you want to try. Once you were done trying, the app would spit out a prescription. They fit short receiver, small dome. This is the color they like. This is how they like their program, hearing aid program. You take the app to the front desk, and the front desk person had a box with that setting. They'd just hand it to you. You would pay and go.
For the dome, do they have a comparison?
Yes, so in these compartments, let's go back one more. All of these domes are different sizes, and the app had some text to say, does it feel right? Is it too loose? Etc. Okay, so after all of this, you've gotten the hearing aids, and you go home. You're on your own for 6 weeks. Let's see what happened. Outcomes. The first outcome that the primary outcome was the profile of hearing aid performance, where you ask the question ask questions like, when I'm listening to a speaker who's talking to a large group and I'm seated toward the rear of the room, I must make an effort to listen. And you go from never to always. There's, I forget, 66 questions, and there's a scoring method, and you get a score. The higher the score, the more trouble you're having. So I'll walk you through the scores and how we get to the comparison for this, and then it'll be easier for the rest. So here are the FAP scores for the three groups, A, B, C, D, and E, F. Remember, higher, the worse. They're not very different. Okay, so we know that the groups start out about the same place. Now let's add session 2 and session 3 for these groups. Okay, now within each group, you have session 1. This is the baseline I had shown you. 6 weeks, improvement. 6 months, improvement holds. What I want you to do is compare the three groups. And it's about the same amount of improvement. Okay, and now what I'm going to do is compare CD or EF to AB. Okay, so, well, before I do that, sorry. So this is here. So if I subtract session 1 from session 2, I get a benefit. If I subtract session 1 from session 3, I get a long-term benefit. And this is the benefit. Short-term, long-term for AB, CD, EF, you can't tell the difference.
Well, it might be very interesting to look at those people that did not benefit.
Absolutely. Yeah.
That would be listening.
Okay, yeah, so naked eye looks like they are about performing the same. And here's the difference between groups. Here are all the people that finished. So this is the per protocol group of 465. The close symbol is the difference between AB and CD. And the open symbol is AB and EF. If any of these symbols would fall below this red line, you would call CD or EF to be inferior to AB. They don't even get close. And this is the intent to treat. So this is imputed everybody who started, same result. It's pretty incredible. Secondary outcome, the HHIE, another very popular questionnaire. Same outcome. Baseline, improvement. Improvement looks similar across all three groups. And here's just the benefit. Both session 2 and session 3, they look really equivalent. Calculate the difference. No one approaches inferiority. Okay, so it looks like this very simple rudimentary hearing aid self-fitting gives the same outcomes that audiology best practice does. Okay, so far the primary and secondary outcomes don't show these CD and EF groups to be inferior. Let's stress test a bit. We stratify the data to those who have mild hearing loss. And in here, we are showing 6 weeks and 6 months difference between the two groups. For the per protocol group, the intent to treat group, no one approaches inferiority margin. Up here, so this is HHIE and this is FAP. Both outcomes show the exact same thing. Interesting thing happens when you look at those with moderate hearing loss. Still statistically not inferior. However, you start to see some data. We're starting to see some interaction with degree of hearing loss and success of these methods. Okay, so far, CD and EF are not inferior, and results hold when stratified into mild and moderate hearing loss statistically. Let's look at some other outcomes. This is a general health scale, PROMIS Global Health, and we looked at two subscales, physical and mental. Physical, here each symbol is one of the groups, A, B, C, D, E, F. This is at baseline, this is at 6 months. Not much difference, but great improvement, not great, but statistically significant improvement in the mental health scale. So the mental health subscale asks about quality of life, mood and ability to think, satisfaction with social activities, feeling anxious, depressed, irritable. And the hearing aids, no matter how they got fit, seem to make a difference there. So that's, to us, an important finding. Next, we wanted to see how confident people were handling hearing aids. This is a test where someone asks you, here, put your hearing aid on, and watches you do it, and then rates how well you do it. Okay, we call the fast start. This is session 2 and session 3. What you can see that every group, A, B, C, D, and E, F, there is a slight improvement, but the comparison of interest here is across groups. So if you do that, session 2 and session 3, what you notice is there is a slight drop in confidence from A, B to C, D, and E, F. Similarly, here's another questionnaire that tests confidence in handling hearing aids. It's not a physical act, you just answer questions. And the results look very similar, where in session 2 and session 3, the AB group seems most confident in handling their hearing aids. CD and EF are less so. And finally, daily use. Overall, people use their hearing aids 7.5 hours a day, which is great. However, those who went the audiology route use it about an hour more per day than CD and EF. Okay. This is great outcome. If people are using 7 hours of hearing aids from day one, this is great outcome, but there is a difference from audiology. So now to fill this table out, what we have already seen is some people decline. We lost a few to follow up. Let's ignore that. And here is the number of people who returned their hearing aids. And then if you combine the number of people who returned their hearing aids to those who declined or were unable to get the treatment at all, you get to a number of people who did not get the treatment. And there is a significant difference between A, B, C, D, and E, F, where 7.5% of the folks did not receive the treatment for one reason or other in AB, almost 20% in CD, and also 20%, around 20% in EF. Now, these are bigger than this, and we should look to see if we can narrow the gap. But if 80% of the people keep their hearing aids after doing minimal effort to get them, it's a win. Okay, so observation so far, these results are not very dissimilar from others that have been published. It's just more people, more outcome measures. We could probably do more with these results. Our design of the fitting system and the price was set before OTC hearing aids, therefore was crude. I think we could do better today. All 3 groups got the same high quality devices. This to me is a matter of time where people will know what devices have high quality, what don't have high quality. And we should be beyond this sounds crappy debate very soon. The audiologist who was measuring the outcomes was blind to group assignment, and few participants refused to or were unable to self-select, self-adjust hearing aids. And then this I've already said, the interest in our study grew tremendously once the FDA rule was published. So overall, individuals with self-perceived difficulty in hearing can self-manage the process of onboarding with hearing aids with reasonable success. However, the data show clear trends of what scaffolding might help those who self-fit. So can I self-fit a high-quality hearing aid reasonably well? Yes. One major question answered, but in our minds, a lot of important questions remain. Do I need a hearing aid to begin with? Should I buy OTC? Should I go to a doctor? which hearing aid should I get? Then after you've gotten one, would I get more out of OTC hearing aids? Someone help me. Could I benefit from additional help, information, the traditional oral rehab route? These are all questions that remain, and remain in very specific ways. So Jasmine Singh, who is in my lab, is going to start her own lab, has been exploring this space of how consumers feel about OTC hearing aids. And right now, about 80% are neutral, are not very comfortable of getting hearing aids online. And even after getting a hearing test, about half of the folks are still not comfortable not getting hearing aids through a medical provider. And when we counted, 84% of this group preferred in-person model of hearing healthcare. This is early days. We think this will change because today I sort of think of the hearing aid marketplace as the market around the corner from my mom, where it's really undifferentiated. You walk in and there's the flower vendor, the fruit vendor, the fishmonger, all in one place. And what we need to get to sometime soon is a segmented market with known consumer patient archetypes where people know what aisle to walk down to get what they need. So in the current system, we have leakage in all stages of delivering hearing healthcare where people take some steps and then drop out. And all of these processes and tools, in my mind, need to be optimized to get to the optimal outcome. So what's next? Self-management, of course, navigation to and support for the most appropriate form of hearing healthcare. I believe we'll get to a continuum of self-driven versus professionally managed hearing healthcare. And we should use technology and care extenders to the biggest extent possible to increase our reach, and then try to get hearing healthcare to be efficient and effective in place. So there's a lot of movement to get retail electronics, pharmacies, etc. involved, and all of that is good, but not any one of them is the end all and cure all in my mind. We need to invest in more than one channel. So yes, we have dealt with maybe a couple of these bricks. We know the cost has gone down, but many of us believed from the very get-go that the cost was not the only thing that needed to change. So we still come back to this gap that we have to work on. And indeed, the nation or the people in the field didn't stop with the OTC hearing aids. There are ongoing national efforts that are trying to explore the next steps and figure out how the remaining gaps need to be filled. And I hope all of you will continue working in this area because there's a lot to be done. Thank you. I promised I'd save you a lot of time. I don't know if it's a lot, but I'm happy to talk.
Wonderful. Thank you very much, Sumit. Great. Let's open the floor for questions. Yes, Jennifer, we'll start online.
We have a question from Chris, which is how do you know that the hearing aid doesn't increase risk for noise-induced hearing loss, especially with self-adjusting out?
This has been a concern, not my own, but in the field, to the point where the maximum output was challenged initially when the FDA put it out. My personal view is that we should trust the hearing aid user not to over-amplify themselves. And I'm not just saying it out of this gut feeling. You'll remember maybe mid-2010s, there was this big hue and cry about how everybody's killing all their hair cells because everyone started using earpods or some kind of earphones in their ears. You know, and some of the studies were ludicrous because, you know, these are microphones that are speakers that are vented, so you can hear them from outside the ear, and people would say, well, I was on a train and I could hear the person's earphones from, well, yeah, because it's vented. And you can hear it. We did a study that was published in 2017 in JASA, where we did real ear measurements with insert microphones at people's eardrums to measure self-set volumes of their chosen ear, whatever earphones they chose to use. 98% of users were well within safety limits. Even going back, there's a group out of VU that had identified a small set of individuals, I don't know if they were any particular kind of individual, that always set their output too high. And they even had some kind of addiction label to it. But outside of that small group, anybody who has ever measured accurately at the eardrum has seen that people self-regulate pretty well.
I have a question. This is for excellent presentation, very clean, very informative.
I will tell my wife, you said.
So the question, going back to the trial, you know, the issue of external validity, generalized opinion, but that was a highly selective group, right?
Self-select. group, yes,
Self-selected, for me, almost a continuous sample.
Yeah.
And then there were losses. So instead of a trial, they have become an observational study. Because we don't know the losses were random or not.
They were probably not, you're correct, yeah. And these are things that plague pretty much every trial, that's for certain. One thing you haven't mentioned that I will say, one of the self-selected criteria that drove a lot of who came in was the price. You know, so when we set it at $650 a pair, we thought we would have lines out 5 blocks, because at that time, to go get a pair of prescription hearing aids, you had to pay at least $2,500, and you would not get anything this quality. That was, we did not, and you guys already knew that, I did not, so I spent a lot of time in community centers, in churches. And 650 was, you might as well ask them for, you know, buying a house or something like that. So that's something we have to think through carefully.
Sumit, I would say, I think, as much, I knew this study was sort of ongoing, but I didn't realize you had results yet. So this is really, this will cause a lot of hand-wringing and consternation, depending on which audience you're talking to. I completely buy the idea, generalizability issue to some degree. I mean, for some audience who report it, they'll do fine. Other audiences may not, they really need an audiologist. And really, how well you plan to respond when you present this at an audiology meeting? And they're like, well, what is our role then as a field? I mean, it's a big open question with no right answer. I think the field's evolving with technology and needs and things like that. But I mean, what's your take on it though? It's such a huge one.
It's a you know, personal take on it, but I think the data already start to show some avenues where there's value to be added. And, you know, I talked about those main points already, but then, you know, Frank, it's gonna be, is there revenue there or not? Is there a sustainable practice just doing that or not? And in some ways, I feel like designing a healthcare solution with the profession at the front end is maybe not the best approach. So here is the outcome, and here are the needs. And it would be me as an audiologist or other audiologists' responsibility to figure out how to leverage those needs in creating a practice model that helps me sustain my career or sustain the profession. So that's sort of a kind of a nuanced answer. But the other big answer, I still think, is if you just go beyond, say, 70 years old, there's a huge market there that I think will remain and grow. And just our experience of the interest in this study with the announcement of OTC regulations, if that is any sign, there's a big shift in awareness at least. And the other, I mean, there's a lot to say, but I'll just say one other thing, is that we can't stop thinking about this business or this marketplace at the first set of hearing aids. And if we can get people to start using hearing aids at 50, we probably have 4 cycles to go through. And those subsequent cycles will more and more likely be in the hands of a professional. So I don't feel threatened, or I don't feel like it's the end of the world at all.
Emmanuel.
Hi, Will. I have a question about the post-feeding services. Do you have any thoughts about it? In terms of, like, yes, it's true that people they can get a self-healing hearing aid, but a lot of the time these devices break, they get soiled, they will need like some sort of repair, some sort of adjustment. So what are your thoughts on a model like this for like a long-term maintenance of devices?
Well, so the question feeds into Dr. Lynn's question in some meaningful way as well, is that also a segment of the business that could be useful or professionals could step in. That said, you're absolutely right. As this market started growing, a lot of us would get calls from anybody and everybody thought people see like 30 million people who don't have a service, and it's $1,000 a pop to provide that service, and it's a very attractive market to enter. And I can't tell you how many of these ventures go belly up because they don't have a plan for the after fitting care. One of the folks who have survived and are doing well, what used to be Lively now is Jabra Enhance. There was a time when they're doubling their on the telephone helpline service every month. Because as their business grew, so did the calls for help after. So what are we seeing? What we're seeing are tiered services. So, and I'll go back to Jabra Enhance. For every product they sell, they have 2 tiers of sales. One is it's the base, you get the device and you get an online help site, and soon enough an AI avatar that you can converse with. And then at the second price point, you get so many hours of professional help post-fitting that you could call and get service. So I suspect that we'll see some mixture of this kind of service being added in, either at the very onset of getting the service or as a fee for service after. That's my naive observation. And others in this room know more about this than I do, so please jump in.
Any other questions?
I have a very specific question, but I'm just curious about the slide you showed where there was, I think, 20% of the participants return their hearing aid for the CD. Yeah. Is there anything that kind of stands out to what differentiates them? Or was it the confidence level, or?
Yeah, so I don't know that yet.
Okay.
This is so brand new, have not gotten to that layer of analysis. What I do know is this is kind of the trend in every small, large study that has been done so far. return rates are higher in non-audiology branches. Now, 20% is not out of the world. There are audiology practices that have return rates that are that high, right? So it's not quite a different planet. That said, early anecdotal reports from manufacturers of OTC hearing aids puts that number pretty high. They're accompanied. So, for example, there are a few that are publicly traded, and this is part of my problem because I have to kind of scrounge around all these non-conventional sources to learn things. I've read a few of their quarterly SEC reports and whatnot. Seen return rates, return of goods rates as high as 35–40%. So these companies will have to deal with that in some way. And again, a lot of people in this room know a lot more about this. In some ways, the lower price invites you to try. And maybe that has some in the equation, it also feeds into the return rate.
Jaleesa?
With putting the increase of self-administered hearing times and learning your like hearing number and whether what your ranges of where you fall with hearing loss, if it's now a bit more severe. If you have any thoughts of how maybe that could be as a guidance of whether or not over the time period would be beneficial or going directly to an audiologist would be.
That's a great question.
I'm so sorry. Do you mind stepping just a little closer to the mic? If everyone can hear us.
Oh, sorry.
Thank you.
Okay. So the question was, if we had actually measured, we did measure their hearing loss, we didn't do anything, chose not to do anything with it. But if we had fit their hearing aids to their hearing loss, would the return rates be less, or would we have more success? And then generally speaking, how does that play into the OTC world? So I haven't again done the analysis yet, but I think there may be some truth to, as we move farther and farther away from that one cartoon audiogram that we used, that people were misfit, so to speak. And there's no reason to start with an audiogram. There are plenty of self-fitting where you adjust the hearing aid yourself based on your thresholds already on the market. And I would think that our results for the moderate hearing loss would be better if we had used one of those models. So completely agree. Now, generalizing a little bit more, I don't even know whether you need to exactly measure the audiogram, or you could get, like, if you did some machine learning categorization and had 3 audiograms to begin with, then you somehow got people to the right ballpark versus started from one, you might end up in the same place. So ultimately, it may become so cheap to have you measure your own audiogram. It already is kind of, that it doesn't make any sense not to have a self-fit hearing aid. But till that point comes, I don't know that everybody needs to build products that are measuring audiograms. There are probably other steps in between that still gets the help to people at a price point that they can work with.
Any other questions online? Okay. Very good.
Thank you very much.
Yes, thank you all. Appreciate it.
That's why I asked these questions.
I can. Thank you. I will be. Okay. Okay, that's right. Okay. We can go to your